Now today is tagged Taking Action and Sustaining Advocacy. Yesterday was a lot practical. Today will be, looking at specific commitments, specific action points, and how they all are to play out. All right? Now, if we look at our agenda for today, after arrival and recap, which we will take in just a bit, there is a presentation that is supposed to come before the plenary session 1. It was supposed to be yesterday, but like I explained, the facilitator was unavoidably absent. Now he's here with us. And that presentation is tagged Building Partnerships, Collaborating with Organizations and Stakeholders, Building Coalitions and Networks. That will be taken by Dr. Aminu Magashi Garba. I'll introduce him properly when it is time. So, but right now, we need to take a recap, very brief recap of what the takeaways from yesterday, and then we will come back. I'll be back here to now introduce our first speaker for today. It's going to be an exciting one, as expected, and very, very practical, very, very hands-on. All right, so I would call up the chief midwife for the Together for Healthy Families in Nigeria Programs of Scale to come and give us the recap in the person of Mrs. Hannah Tudung. She would give us a recap, and then we would set the ball rolling from there. Please, a round of applause for her.
Okay, so day 2 of the workshop commenced as early as 8:45 a.m. May I also beg your indulgence to stay on existing protocols? I greet everyone this morning. So I said day 2 recap, key points. Yesterday, the staff of T-Connect read out the day 2 recap, but I will reiterate a few points out of that. So it commenced as early as 8:45 a.m. and with the country director, Professor PDG, Professor Emmanuel Lufadeju, welcomed the guests and present all, and also gave a brief highlight of what the day's activity will be like. So the day's activity actually commenced in NS with Professor Shitu's presentation. His presentation was on core advocacy, where he defined advocacy according to the Oxford Dictionary, where he said that it's an active support of an idea, cause, or proposal, especially the act of leading or arguing for something. He gave several definitions, which I may not really read out. And so, but what some of the things he talked about were that there are steps, key steps, when one is planning advocacy. And here he outlined about 8 steps. These are identify, analyze the problem, formulate the proposal, analyze the decision-making space, analyze channels of influence, do a SWOT analysis, design advocacy strategies, and develop an activity plan. Then carry out continuous advocacy, because advocacy is not a one-off thing. It's something that has to be repeated, should be continuous. And then after then, there was a presentation, a breakout session, where the groups were divided into 3 groups, and every group was given topics to discuss on how we can plan advocacies to be able to reduce maternal mortality. So indeed, before the breakout session, there was a presentation from Nasarawa State by the Nasarawa State RH and FP coordinator, who shared what they are doing in Nasarawa in regards to advocacy to support family planning, where she talked about the fact that they are also working with the interfaith, the traditional leaders, and as well as the policy makers. And so that there was also a presentation by the Chief Imam of Abuja, of the National Mosques, where he emphasized the importance of the influence of religious leaders in promoting access to sexual and reproductive health services. On the overall, he said that both major religions do not support giving birth to children mindlessly without having the means to take care of them. So then there was, after then, there was also a presentation from the, there was a breakout session where, there was a presentation by the National Health Insurance Authority, where she said that National Health Insurance Authority supports access to maternal and child health services in terms of financing. And so after then, we went on to the presentation on the identifying the key stakeholders and planning the advocacy. So during that time, group one was to targeted the traditional leaders, group two, the donors, and group three, the executives. And that was well presented. That is to say that that happened after a role play that was done by, after the presentation by the Division of Health Promotion in the Federal Ministry of Health, where they tried to see how we could put together the learnings that we have had to be able to present our advocacy when we are carrying out advocacy to ask for support. So by and large, that is what happened yesterday. The workshop came to an end by 5:17 p.m. and we all went to have our lunch, after which every participant retired to his or her room to rest. Thank you very much.
Thank you very, very much, Mrs. Hannah Tudung, for that recap. At least that forms a very good foundation for today's learnings to sit on. So without much further ado, we'll be taking the first plenary session for today. It's building partnerships, collaborating with organizations and stakeholders, building coalitions and networks. It'll be taken by someone who is a coordinator and founder of the Africa Health Budget Network. He's a technical advisor, Kano State Ministry of Humanitarian Affairs and Poverty Alleviation. As a member, Every Woman, Every Newborn, Everywhere Advocacy and Accountability Working Group. As a chair, Nigeria Medical Association, National Health Policy and Planning Committee. And of course, he's the publisher, the online health newspaper for Africa called Health Reporters. Please, let's make welcome to the podium for this first plenary session, Dr. Aminu Magashi Garba. Please let's keep clapping till he takes the microphone. I think the applause can be louder. It's early in the morning, so there should be a lot of energy in the room. Thank you, thank you, thank you very much.
So, thank you very much, the Master of Ceremony, my distinguished Prof. We have been together one of the RAMCA platform, which I will also mention, part of the partnership. Distinguished Rotarians, the governors, and all the high-level titles, which I'm learning also this week. And TA Connect, one of the partners for the meeting, and the office of the advisor to Mr. President on Health. So we can already even see a partnership in this room. Now we are discussing. Three groups work together to make. So I will have a conversation. Let me know how many minutes, the MC, how many minutes is this session? So, okay, 30. So I will provide an overview of my understanding of the partnership and also building stakeholders and collaborating and the coalition, maybe for 15, 20 minutes, and we can get some contribution and maybe Q&A in the process. I didn't make any presentation because I felt the partnership should be about a discussion. And like I said already, we have 3 powerful partners coming together to organize this session, and that's what partnership is all about. So the biggest question we need to answer is the partnership for what? So the so what question needs to be defined clearly if we're discussing partnership. Partnership for what? The partnership for maternal health, reduction of maternal mortality and morbidity. The coordinating minister has introduced a new phrase, crashing. He brought that when they launched the swap, crashing the maternal death to the barest minimum. So the partnership is to reduce the morbidity and also mortality. The partnership is also for ensuring that our women are attending antenatal care in line with the WHO requirement. That's also another partnership. On Tuesday when I came, there was a discussion about a facility in one of the local government. This is part of the partnership, ensuring that all our pregnant women are attending antenatal care, and the majority of them, or even 100%, they are delivering at the facility, or they are being delivered by a skilled birth attendant. This is the partnership for. Then the partnership is also for ensuring demand creation is done very well, building stakeholders, awareness creation, building partnership with the media, and also building community structures, working with traditional rulers, and also the religious leaders. This is also another form of the partnership. And also we should not forget that we have emerging challenges in Nigeria, which before we didn't have such insecurity. So insecurity has also created a new paradigm and a new partnership for the health sector. Because if you go to a particular facility, majority of the health workers, they are in a hurry to close by 4 p.m. because of insecurity. Some of them will not stay in the facility for the whole night because there will be a challenge for harassment or challenge for insecurity for the health workers, for the patient. This is a paradigm which I'll also discuss as we intend to build intersectoral, multi-sectoral, and multi-stakeholder partnership. So the health sector cannot operate as an entity. We have to find a way to build a lot of partnership, building stakeholder mapping, and also building the collaboration and the coalition beyond the health sector. 2 weeks ago in some states, the Nigerian Medical Association, they threatened to go on strike because a health worker, a female health worker, in the evening, she was being attacked by some hoodlums. And because of that, they said they are going to withdraw their own services. That has a significant effect on maternal health. If the health workers are withdrawing services in the night, that means all our emergencies cannot be taken care of. Obstetric emergency, bleeding could be postpartum, prepartum, antepartum, and convulsion, eclampsia. All these problems, if they are withdrawing services, it means they cannot be attended to. So this is the reason for partnership. The partnership is to address this concern, improving maternal health, increasing birth attendance by skilled attendant, improving antenatal care, addressing postnatal services, addressing complication of pregnancy, bleeding, infection, eclampsia, and so many other things. So we need to build partnership for that. We should also build partnership for accountability. That's also another way. So building partnership for services, which I'll explain now. Then we also have a building partnership for accountability. That's also very important. The accountability to deliver. The government has made a lot of promises. Who is holding government to account? So a coalition building and a collaboration is also important to ensure that the promises that our state governors are making, the promises that our Mr. President has made, the coordinating minister, the SA to the president, and everybody, we are also holding them to account. So we can build partnership to monitor, to review, and to take remedial action based on the promises being made by the stakeholders. So we can also do that. So partnership for financing, that's also very crucial. So partnership for accountability and to do a scorecard, maybe a dashboard to track progress using existing data or secondary data to improve services. At the same time, we can also do partnership for financing. That's also very key. Where is the money coming from? How do we track the money? Who are the partners that will work together with the Rotary, the THFN, and so many other partners to track the money for maternal health, from the budget up to releases, utilization, and also changing the narrative at the facility level and also at the community level. So we can also build the partnership for financing. But for us to build partnership for financing, we need to know the amount of money the government is allocating, the amount of money the partners are putting on the table, and also the amount of money the big donors are also committing to support maternal health and primary health care services. So this is the reason why we should build partnership. So the next issue is, where are the mechanisms that we need to also work together as NGOs, as government, as partners, as donors? Where are those structures? So previously, before this new government of President Bola Ahmed Tinubu, we used to have the, what you call the RMCH plus N coordination partnership platform, the RAMCA platform that we are all aware. So it used to be when Dr. Salma was the Director of Family Health, just before the COVID-19, the RAMCA platform was reorganized with term of reference and also with a lot of energy in the room. It's a very big partnership to look at multi-stakeholder partnership coordination platform, the RAMCA, very popular in the previous government. And within that RAMCA platform, the Minister of Health and the Minister of Women Affairs were the co-chair, for the partnership. And the partnership has done a lot, over the years, organizing biannual meetings, organizing quarterly meetings, engaging in advocacy. Myself and Prof, we have done a lot of engagement at the level of that partnership platform, the RAMCA platform. A lot of strategies were launched, were presented. The Family Planning 2030 Nigeria's commitment was launched, during that period. The 5-year strategic plan for RMCH plus N was developed and also presented and launched. And so many other guidelines were developed as partners. And within the partnership, we have different technical working group. We have the partnership coordination and the leadership subcommittee, where you have the donor partners, the H6, the government, and so many other intergovernmental bodies also as members. We have the reproductive health technical working group. We have the service delivery. We have resource mobilization, advocacy, and communication. So this was before this new government. So in engaging in partnership, we have to also understand the dynamics. So with this government, that partnership is still available around, but it's no longer strong. Because there's a new government. There's a new sheriff in the house. So that partnership used to be very strong, very powerful, but now it's still there. I know the Ministry of Health could be around in the room. The RAMCA platform is still there, but it is no longer the main, aggravating factor around different partners. So the new government introduced the sector-wide approach. I want to believe either Tuesday or yesterday, somebody has mentioned the sector-wide approach, the SWAP, which is being led by the Coordinating Minister of Health and so many other agencies. So within the sector-wide approach, there's 7 technical working groups where also discussion and partnership is also taking place. The sector-wide approach, according to the coordinating minister, is to promote one conversation, one report, one plan, and one budget. That is the whole idea of the sector-wide approach. Some of you probably are part of the discussion at the state level, where every state has now established a swap desk officer. And also 2 weeks ago, the minister organized a joint annual review of the sector approach, and all 36 states commissioner of health and their own team were in the room. So this is another platform that we are now, as NGOs, donor partner government, we are also engaging. And within the sector-wide approach, there's a technical working group on RMCH plus N, which I'm hoping that in your communique and your discussion that we need to engage, which is being co-chaired by the Director of Family Health at Federal Ministry of Health and the UNICEF and the National Primary Healthcare Development Agency. So that's another new TWG that is also helping to promote partnership. There's also within the sector-wide approach a committee called State Advisory Group, where all 36 commissioners and all the state officials are also having conversation. There's also a group on resource tracking and mobilization, and also another group that is being chaired by NHIA on Vulnerable People Fund. I'm sure you know that the NHIA is a revised act signed by the former President Buhari in 2022, which replaced the National Health Insurance Scheme to become a National Health Insurance Authority. So within the authority, they are expected to establish a Vulnerable People Fund that will mobilize resources to scale off coverage of insurance scheme. So it also has a technical working group that is also looking at that. So these are all examples that I want to provide for the partnership that we need to know and we need to also engage. Now, you are also aware of the Basic Healthcare Provision Fund. Many states are receiving big money, from the Basic Healthcare Provision Fund. This is a statutory allocation. Every year, the federal government allocates 1% of consolidated revenue fund to now mobilize money for 36 states plus FCT. So Nasarawa State is part of it, FCT, Gombe, and Ekiti, and all the people in this room we are receiving on quarterly basis Basic Healthcare Provision Fund through National Primary Healthcare Development Agency and the National Health Insurance Scheme. There's also another gateway on the emergency maternal health ambulance services, where women are being supported at rural area to reduce the delay in transportation when they have complication. That's also another partnership where there's a ministerial oversight committee at the federal level. There's also a state level oversight committee, MOC at federal, SOC at the state level. And because of the nature of the oversight committee, is about how the money will be mobilized, how the money will be utilized, and how the money will impact positively on maternal health. So I also want to flag that that's also another huge area of the partnership that we should be also talking about, and how do we build a coalition across different segments. There's also another partnership that I want to also flag. That is the multi-sectoral partnership. The social determinant of health also requires that we also build partnership and collaboration outside the health sector. That's why we call it a multi-sectoral partnership. Multi-stakeholder is within the health sector. We should also attempt to do a multi-sectoral partnership, because like I said, the issues are changing. So multi-sectoral partnership, we need to move beyond our comfort zone in the health sector to also engage different sectors. If you go to a facility, if there's no water, so that means it's no longer a health issue. We need to bring the Ministry of Water Resources to the table. Because if there's no water, that means it's beyond, the pipes are not working, they are not pumping water, the borehole is not working, so many other problems. That is a multi-sectoral collaboration. The health sector needs to engage the Ministry of Water Resources to now ensure the partnership is also done very well. Because if there's no water in the facility, infection prevention control will be compromised. Very simple things will be compromised. The women that we are attending to for antenatal care, they will get more infection when they come to our facility because there's no water. The theater, the operating table, the delivery room, if there's no water, then it's going to create more hospital-acquired infection, and the partnership, it has to be done between the health sector and water resources, or the local government chairman, in that local government. So this is also another partnership, multi-sectoral. You move beyond the health sector, beyond our comfort zone to engage water resources. And these are very important issues. Water in the facility, we take it for granted. It's very important. You go to some facilities, teaching hospitals, they are bringing water through Merua, those jerrycans. Secondary facilities, primary centers, they don't have a pipe-borne water, or there's even no borehole, or the borehole is there, but the solar is not working. So you have to start seeing a lot of young boys, pushing the jerrycan into the facility. This is not theory. If you are going around, I'm sure some of you could share experience, teaching hospital, not even secondary. Some places, even federal medical centers, you see people, young boys, pushing water in a jerrycan. So you can begin to see why maternal death could happen because of the infection and there's no adequate water. So this is a partnership that we need to build. Then we also need to build the partnership with the security apparatus. So we have to move beyond the health sector to also build another partnership. A woman in labor, by 1 a.m., everybody in that community is afraid to convey that pregnant woman to a facility because of security issue. So if she's dying, she's not dying because there's no care. She's dying because the transportation is a challenge. And it's not because there is no transportation, no, because it is available. But because of insecurity in that environment, everybody is scared to convey the pregnant woman to a facility. And even if there's no insecurity in that area, if we did not build partnership with the police, as a tricycle is conveying a woman in labor, they will be stopped at the checkpoint. And they may end up spending 15 minutes there arguing and debating. This is practical. Arguing and debating with the police while the lady is in labor. So this is a challenge. So that means the partnership is not only health. We have to build the partnership with the security apparatus to understand that if we don't allow this vehicle to pass through, the lady inside may likely die or she will have complications. It means we have to build partnership across many stakeholders. And this is what we are seeing every day. The people are stopped by the roadside and they are trying to talk and argue. The person will suffer a lot of complication or lose a lot of blood because of that issue of whatever you are going to agree as your person. Or even in the entire environment, people are scared to even drive the women because of the fear of being harassed. It means as partners in progress, we need to bring the police to the same room. We are discussing partnership. We need to bring DSS to the same room, the National Security Advisor Office. At the state level, we need to bring the police commissioners, the DPOs. People assume that those are important. They are very crucial in addressing maternal health. Because if they do not allow things to move freely in our communities, it means our women will be dying by the roadside, or they will be dying when they are being conveyed to our place. So this is also another challenge of building partnership, the security issue. That is another multi-sectoral layer of partnership, coalition. It means the NGOs in the health sector, we need to move out of our comfort zone to really engage different stakeholders. Another partnership we need to build is the power sector. Power sector. That's also electricity. It's not available at facility level. Some people will tell you that when the national grid collapses or keep collapsing, the oxygen cannot be pumped through the pipes in a facility under emergency because there's no electricity. There's oxygen, but it cannot be utilized, and a lot of children, a lot of mothers will die because of that issue. That means we need to build partnership also with the power. A teaching hospital somewhere in Nigeria wrote a story just last week that they spend about 80 million naira every year just on electricity alone. And it's no longer sustainable, it's no longer tenable, and they cannot do it anymore. So innovation in a partnership. They could have invested that 80 million naira in solar energy or maybe in another renewable energy to address the concern. So the building partnership with the power sector is very crucial in addressing maternal health. So, like I said, the whole idea of this conversation is to, have a paradigm thinking that the health sector cannot operate as an entity because the challenges in Nigeria, they are daunting, there are so many, and we have to engage different stakeholders. Transportation, multi-sector, between health sector and transport, conveying our women to hospital, conveying them to pharmacy, to obtain drugs. A lot of roads are not motorable, or there's even no road in so many places. There's even no public transportation in a lot of places. That means a partnership is also required in building, that approach. So we can see in a summary example of a multi-sectoral partnership. The education sector can also help us to graduate more women, more midwives, more doctors, more pharmacy, more health workers to also support addressing maternal health. So multi-sectoral partnership, we need to have education on the table, the water resources, the power and energy, the electricity, and the security apparatus, very important. We are still struggling in Nigeria with police reports. We are still struggling because the partnership is not strong. We are still, a medical doctor will deny to attend to some complications because there's no police report. We are still struggling. Till today in Abuja, where we have almost everything is working well. Even here in Abuja, they will tell you, go and get a police report. When the patient is already bleeding, the coordinating minister and the AG of the police, they even issue a press statement that if there's complications, it does not require a police report. The National Health Act has also emphasized certain conditions do not require a police report. But the police are still demanding, and also the health worker. What it means is we need to build a bigger partnership than a smaller one. So the DPOs are not aware. If a coordinating minister and the IG of police issue a joint statement in a press statement, who is going to see that? Will the DPO in a way, where even my office is also here, just for you to know. So will the DPO in a way read that press statement? Will he be aware? Or the divisional crime officer? Or the transport police officer? It means as we build the larger partnership, we also have to build a smaller one with the police to understand that this issue has to stop, where if there's complication, we have to get a police report. So these are all examples of partnership, just to see beyond the health sector, the agriculture, also food security. The women are not being fed very well. They come with anemia, during pregnancy. They are malnourished, so the pelvis could not even accommodate to deliver a baby. It means they have to also feed well. They have to eat well. We need to have a nourished food in our environment. We need to cultivate farming. We need to also ensure that the food is affordable and also clean, and also the environment is sanitized, and will also improve the maternal nutrition. We can see agric now play also a critical role in addressing maternal health. So the whole idea of a multi-stakeholder and multi-sectoral partnership is that everybody has to be on the table. That should be, to me, the slogan as we leave this meeting, that everybody in Nigeria must be on the table to address maternal health. Because it's no longer a health issue, it's a security issue, it's a financial issue, it's an agric issue, it's everybody's business. Another, in summarizing another partnership, tell me how many time remain for me? 5? Okay, so I think I should wrap up the 5 so I can get some feedback. So another summary is that the National Assembly, that's also important, building partnership. The State Assembly, they are the one making the laws, they are the one approving the budget, they are the one providing oversight function. They have a statutory function to go around the facility and see what is going on. But a committee on health, they can spend 12 months without going out once. You should go and check. A committee on health at the National Assembly or as an assembly, they can spend the entire 12 months. They have not gone out once for any oversight function. You see? And it is statutory function. So that means we need to build partnership with them to keep pushing and nudging them to ensure that they are doing the role of the oversight, to check on facility and see what is going on and how things are happening. And that is the business to strengthen. So we need to build partnership, Prof, also with the National Assembly, with the State Assembly, the Office of the President and the SA to Health, and the National Security Advisor. Somebody could see is very far. That person is not far. Because the National Security Advisor Office is also coordinating all the security apparatus. So that NSA need to be aware what is going on in the health sector about insecurity and how that is going to affect the health workers. So I want to pause here. So if there's any quick feedback or any reflection from what I said, or if we are moving to another paradigm shift, I'll be happy to listen to any contribution by the distinguished and esteemed participants. Thank you very much and God bless.
Feedbacks, questions, I'm sure there will be some. Just indicate with a show of your hand. I'll bring the mic to you. Wait. Oh, yeah. All right. Dr. Ibitoye.
Thank you for the very inciting lecture. Mine is not a question, but just to make a statement in agreement with what you have said. I just want to use our own case in Ekiti as a case scenario to support what you have said. You can imagine even our Ministry of Health was situated within the ministry quite well, but the road leading to the ministry itself, Lord have mercy. I think it was just newly constructed, I think last year, if I'm not mistaken. The road was so terrible, and so it is to many other facilities. And the building that we are housed has about 3-4 permanent secretaries. So that was when I raised that issue that, for God's sake, you have a ministry a building housing several ministries, and yet the road leading to the building is in this deplorable state. So all we just need to do is collaborate with Ministry of Works. I'm sure one permanent secretary or 2 of them can just take off and pay an advocacy visit to the Ministry of Works that, please, just come and look at our situation here, and things will be addressed. Hence, what you have just painted is a very serious one, and I believe by the time they did that, within 6 months, the road was constructed and everybody was just driving in. You can even drive 100 kilometers per hour on the same road they were talking about. So thank you very much, sir.
Thank you very much.
I want to thank Dr. Omedu Magashi for such a very insightful lecture. We have known each other for a long time, and I know that you are very operative at the health sector level in Nigeria, and I know what your contributions have been over the years in some of the joint meetings that we have attended together. I am a little worried that, and this is food for thought, when a government sets policy and another government comes and shifts that policy in another way, trying to do the same thing. Please, hello? It's concerning.
Yeah.
Because, you know, the life of a government is 4 years.
4 years.
And if we keep shifting from one policy to another, and we are changing personnel, and we are changing people who have already, they are just settling down. Ramkai is just settling down. Ramkai is about what, 4 years, 5 years when Sama came to the ministry, and all of us were on board. There are a lot of people who don't even know about SWAP. They have been left out. People who are contributed to the development of Ramkai. How do you reconcile in a developing country like Nigeria? I think we should have a 10-year development plan where when a policy is set, anything that we want to do will fit into that policy. SWAP, for example, can fit very well into Ramkai. Ramkai is a coordinating platform for stakeholders to bring all their activities on the table. So there is no repetition in the field, there is no duplication, and everybody will know what everybody is doing. SWAP is the same thing, multi-sectoral approach. What it has added is that there are other sectors other than health that we need to look at, other than nutrition, like we have very well mentioned. Security, water provision, power provision, and things like that. It's just an addition. What is your thought on it? You are a policy fellow. And I believe that it may be belated, my comment may be belated, but I think the discussion is going to go on. If this minister, for example, and another government comes and changes, I would not be surprised if another minister comes and says, no, not SWAP, something else. It's very disorganizing to the brain, the mind, the concepts that people have for developing health in Nigeria. Your comments.
Thank you.
I think you should respond to that while I take the mic to him. Then he'll.
So the observation, Prof, are valid, and to me that's the essence of this discussion. We have to engage. So I'm hoping that we need to find time to really engage the coordinating minister. I'm open for that. So these are concerns that I've also raised in some couple of places. But I think if we build more partnership and we can now secure audience, we meet him and have a frank talk. You know, as we love our country, we want to see progress. We are here to meet with you to now see how all the previous effort that have been done, like the Ramka platform, how does it survive within the reform agenda? So those repertoires of today, we should discuss and secure audience and have that conversation. I agree with you. We need to do it. Yes. Thank you, Prof.
Thank you very much, sir. When you were invited to make the presentation, all I was thinking of in partnership was partnership with this NGO, partnership with that NGO and the rest of them. But my eyes have been really opened, really, really opened, and I can see much more. The other partnership that has come up to me now is a partnership with the community in which we find ourselves. I'm talking as a healthcare worker. Yes, because health facilities are in communities. And if we do not partner with the communities, quite often it's actually a disaster. Many years ago, and I think 1984, when I was heading a general hospital in the state, in Shendam, there were powerful people in the area, but the hospital was going downhill. And I had to meet them one-on-one and to say, look, this is your hospital. You go to Jos every now and then. You may have an accident 3 kilometers from the place, and you'll be brought back to that place. What next? And that sank into their minds. And they formed a community and started having some resources to come in and help the facility. And we started growing up and up and up. So the community participation, our community partnership is very important. And therefore, we are all interconnected after all. All ministries, parastatals, whichever profession you are, we are connected after all. And if we think out of the box in that case, we'll move further than just remaining in one place. I'm in a hospital. Hospital. No. I need to reach out to Ministry of Works. I need to reach out to this ministry and the rest of them, and they will be better off. Just your comments probably to add, sir, with community partnership.
So we can wrap off.
Yeah, we'll just
With
take
the
one last
community.
one. Then maybe just wrap everything up so we can move to the next presentation.
Thank you for your presentation. We need partnership, as just you have said. And you have gone through a list of many persons or organizations to engage. And if we list them, it's going to be it's a long list. I believe there is need for us to prioritize first group of partnership, first level, first level, second level, and the third level. Because if you see you're going to do all of them, it will take you time, consume your resources, and you may end up doing the opposite. Secondly, because of the situation I find in Nigeria, if things were working out normal like other countries, like nations, we don't need all this like police. We don't need like all these things because there's part of their responsibility to the community. But in this such a situation, we pray that things will improve. But my request is that let us prioritize and rank the type of group of partnership, first level, second level, and third level. Thank you very much.
That's a valid one. Categorization of the partnership, and also to understand the dynamics, the political economy analysis of all the different layers of partnership and how we can engage. So that's a very valid point. At the state level, you have so many structures: MSCH Week, MSCH Technical Working Group, Family Planning Core Group. You have the CERIC, you have the RI and MSCH TWG. You have the World Development Committees. You have the community coalitions. You have Council on Traditional Rulers, and so many other structures, at the community level that he also mentioned. So we need to develop a demand creation strategy that work also very well for Nigerians. We have the groups from Islamic groups. We have the Khan. All these are stakeholders, in actually solving a problem. So let the discussion continue, and I hope to see more engagement, and definitely with Prof and everybody, we will push to have a meeting with the coordinating minister to have a very healthy, friendly and frank conversation. Thank you very much.
Thank you very much. I think he deserves a louder applause. Prof even gave him a standing ovation. I'm not saying everybody should give him a standing ovation. That's Prof. All right. I think that was well, delivered, looking at partnership across board. While he was speaking, I recall a friend, I won't mention the area in Abuja, but within the urban center, whose wife was going to put to bed, and there was power issues. I think it was the light on his phone that they had to use to take the delivery in Abuja, in the urban center, but I'm not at liberty to mention what part of it. So this is a very key conversation, and we hope that this goes beyond this. Like Doctor said, many other partners coming together, getting audience with the minister, with the honorable minister, and seeing how they can advance these things so that they are actually put to work. Thank you very much, sir. Now we'll be going to the next plenary session. It's tagged Implementation Strategy for Advocacy, Surmounting Challenges and Charting a Course Forward. In the course of the presentation, the facilitator will be looking at implementing advocacy plans, overcoming challenges and obstacles, leadership, capacity building, and a whole lot more. She works closely with the special advisor to the President on Health. We know she was here with us on the first day. That's Dr. Salma Anas Ibrahim. Please, let's welcome to the podium Dr. Fatima Jibrila for the presentation. Please, let's keep clapping.
Good morning, everyone, and welcome. I'm also going to take us on advocacy. In the last 2 days, from the plenary sessions that we had, and from some of the results and achievements presented by some of the representatives from the state, it is very clear that we all know about advocacy. We all understand advocacy, and we've even explored some of the strategies. And however, I feel we're still going to learn something new from this interaction today. So let's get started. So I'm going to be presenting these topics: implementing advocacy plans, overcoming challenges and obstacles, and then leadership and capacity building. But before we start, I remember that we developed our advocacy plans in our individual groups yesterday. So the question I want to ask here is, do we think our advocacy plan is complete or completed and it's ready for implementation? Is it? Please answer yes or no. Okay, some people say yes, some people say no. Okay, so how do we know if our advocacy plan is complete and it's ready for implementation? Next. So, this is a complete advocacy plan, and you can see with the items, so we have to answer this question. On our advocacy plans, do we have the problem clearly identified? Do we have goals and objectives? Have we identified key audiences? Have we, identified messages or message points for our audience? Have we identified advocacy strategies or communication activities to deliver those messages? Do we or have we outlined our measurable indicators for each audiences? Are there budgets and other resources necessary to complete each of the activities we've outlined? Have we, put any time frame for the whole advocacy project, and then timeline for each activity? Have we assigned responsible persons for each activity, and then have we attached or have we developed any monitoring and evaluation plan to monitor our advocacy efforts? If we have not done that, then our plan is still not complete and we need to work on that. Okay, so now we are all here because we believe there's a problem. Yes, next. And the problem is what? There's high maternal and child death in the country. We are here because we are concerned and we want to address this problem. So there are two ways to address this problem. It's either you invest or we invest in direct service delivery, or we invest in advocacy. So we are here for advocacy. So we have clearly defined or identified our cause that we are going to invest in advocacy to contribute to reducing high maternal and child death in the country, right? Okay, so next slide. Looking at the problem, we know the cause or the causes of this problem are from both sides. There are contributory factors from the demand side of maternal and child health care services, and then there are contributory factors from the supply side of the maternal and child health care services. Yes, we want to do advocacy, but it should be at the back of our mind that we are going to advocate, we are going to advocate for increase or to create demand on maternal and child health care services, or we advocate for improved supply of maternal and child health care services. It has to go hand by hand. It has to balance, because if we have strengthened supply and then people are not coming to access the service, it won't have any impact. And then the other way around, if we have just advocated and created more demand and then the services are not readily available, the same problem. So we want to do advocacy. So we assume that we have developed our plans, because development of plans should come first, even before deciding, okay, when to start, when to implement. So I assume we have a plan ready, and then now we're going to discuss how we're going to implement. So to implement, next time, to implement an advocacy plan, it has 2 stages. There is pre-implementation stage and there is implementation stage. In the pre-implementation stage, we have 2 buckets. There is a preparation stage and then building support. In the second one also, there is the execution and then monitoring and evaluation. And we're going to take them one by one. So, pre-implementation 1, that is the preparation stage. Next slide. Next. So, the preparation stage, what are the steps in this stage? The first thing there is, number 1 is to finalize our advocacy plan. We have the checklist, we go through it and to see that all the relevant items are there and, completed. Then the second one is assemble advocacy team. The third one, identify and engage target audience. Then develop key messages and materials. Then mobilize resources. We're going to take them one by one if time permits. So the first one is finalizing advocacy plan. So to finalize the plan, in addition to the checklist, we need to answer these questions. Have you completed your advocacy plan with all the components, including the budget? Have you reviewed your plan collectively as a team? And there is advantage to that. Of course, what you've not seen, the gap that you've not seen, another person might pick it up. And then, have you agreed that this is what you want to do? So when we answer these questions, our plan is set and ready for implementation. The second intervention the second item under preparation is assembling advocacy team. It is assumed that we have already formed our advocacy team during the planning session, but now this is not talking about the team composition, but it's talking about assembling the team members and making them or preparing them ready for action. So the questions to answer this is, have you identified your team lead? Have you reached out to all team members? Have you had any orientation, training, or rehearsals or role plays to fully equip your team members for strategic advocacy? So these are all under the preparation stage. So the next, we're going to the third one, which is identifying and engaging target audiences. The same thing, we have assumed that we have identified our target audiences since during the planning stage. Of course, before the planning, we must have gone for our situation analysis, and then we have done our stakeholder mapping and all of that. We have identified our audiences. But now, we are going to engage our audiences. So I have a slide here that shows all the stakeholders that will be involved or that will be relevant in this advocacy. But I'm not saying this is the only, or these are the only stakeholders. You could have more. But as far as this presentation is concerned, or what I just identified as relevant is this one. So we have a lot of buckets here. There's the general public. You remember we are advocating for demand and supply of maternal and child health care services. So the general public, yes, policy and decision makers, yes, the private sector actors, yes, the pressure groups, we know them, the media, the civil society organizations, then the healthcare providers, and also our implementing partners. As you can see in the middle, I have a shared goal or common interest of reducing maternal and child death, or if we want to call it as improving maternal and child health, all the same. By improving maternal and child health, we will now achieve reducing maternal and child death, right? So, number 3A, we are still on stakeholders. Because we are advocating for both demand and supply, our target audiences for creating demand, of course, is the general public. And the general public, it's easier when we group them into these classes. Group 1, we have the religious communities. 2, traditional communities. 3, school communities. 4, women communities. And then informal groups are all those other people that cannot fit under each of these groups. We can just group them as informal groups. So these are primary targets or key targets for our advocacy to create demand. So for the supply side, high-level advocacy, who are our target audiences? So we have them as the policy and decision makers, private sectors, healthcare providers, pressure groups, implementing partners, right? So we're going to the next. So the next item under that table preparation is, I said engaging the stakeholders. So we have identified them. We know them. How do we engage them for the advocacy? Do we just go for advocacy on that very day? Are there some preparations or some engagements that we need to do before the D-Day of the advocacy? Yes, we need to engage them first. And how do we engage them? Next slide. Next. Oh, okay. So these are the ways, but I'm not saying they are the only ways. I have others. There are other ways you could reach out to them. We can send the letters to seek for their audiences. We could provide it. We can be in the state from so-so to so-so. You kindly provide us with your availability on so-so date, or can you identify any date that we could meet you between this date and that date, things like that. We could send emails. There are phone calls, and then all other channels or strategies that you think we could reach out and engage, and engage our stakeholders, early engagement, to tell them that we are coming for advocacy. So that is stakeholder engagement under number 3. So the next slide, messaging and materials. Of course, because we are now in implementation, it is assumed that we have developed our messaging also during the planning stage. Yes? So what types of messages do we have? What are the materials do we need for our advocacy? So remember, we're still in the preparation stage. We're making sure we have everything so that we'll be fully kitted for action. So messaging is one of the key things we need in advocacy. And what are those types of materials we need? We should have an advocacy brief, which should contain relevant information, which I will discuss later. There should be a fact sheet to back up whatever argument we're going to present, because advocacy is not just about storytelling. It's not just about gisting or presenting cases. It's about convincing. You should be able to elicit a change, either will, commitment, or any form of change towards addressing the problem at hand. So because you want to convince this listener, this audience, you should have enough evidence to back up whatever information you're going to provide. That is why fact sheets is also very important, to have relevant information that will move the audience, the target audience, to invest in that intervention you want him to. So worksheets, yes, sometimes we include worksheets. I can remember in our advocacy interventions with the governor's wives 4 years ago, because we trained them on strategic advocacy. We also provided them with advocacy worksheets, which we follow from time to time when we go for monitoring. We score the books, we look at their advocacy efforts and all of that. So worksheets, yes. Posters and infographics, social media content, including jingles, other educational materials, including short clips, etc., etc. And then we have T-shirts and other non-educational materials which we could all use for the advocacy. So if we are going to next, that is the 4B, I talked about messages. So we have vast number of stakeholders or target audiences. Of course, we should also have different messages, because for each of the stakeholder, yes, we want him or we want them to, engage in a different intervention. So these are the stakeholders and the types of messages we should have. For general public, of course, we will have messages to sensitize and create their awareness to seek for maternal and child health care services, yes? For policy and decision makers, the types of messages we should have is to create or increase political will and commitment. For RMNCAH, next slide, sorry. Where are you? No, back. Yes, go to 4B, sorry about that. Yes. Okay, so you can see for the general public, it's sensitization and awareness creation for them to seek medical care, the maternal and child health care services. For policy and decision makers, yes, to create or increase political will and commitment. Private sectors, of course, will send messages to engage them to complement government efforts in maternal and child health care services. For the implementing partners, what are we advocating for? We want synergy, alignment, integration of maternal and child health care interventions. A lot of implementing partners are, doing things as silos, so we want an alignment, integration, so that it avoids duplication of efforts, yes? Healthcare providers, yes, we should also advocate to them for what? Quality and effective maternal and child health care service delivery, and also to further advocate for both demand and supply, because they are in that field and they could, convince better also. So the pressure groups, of course, we know them, media, civil society organizations. Why do we advocate to them for what? We want them to create public awareness and also to engage government officials through different events. Yes, so this is all about types of advocacy messages. So we are going to the next slide. Format of the messaging. You remember I said we'll have an advocacy brief. So in that brief, what is the format of our messaging? Even from our role play dramas yesterday, yes, some of us have followed the format, but some of us have not. So first, you have to iterate the need. What is the need for that intervention you're advocating for? So you have to use data and other relevant and supporting information to back whatever information you're going to, pass. Show them the need. Table it to them. This is the problem, and this is why we need you, or this is why we need this intervention to be prioritized. The second paragraph, or depends on how you call it, the next will be workable solutions. You've now presented the need. Of course, he may not be in that field. He may not know what to do. You will also have to provide him with this information, propose evidence-based ideas and interventions to address the problem. You're not saying you must do this and you must do that. No, you could just propose these are possible ways, and it should be evidence-based. We don't want to waste resources, and we don't want them to lose confidence. This is something that they've done and it's not working. No, something that we know it has been done elsewhere and it has worked. So it's even easy to convince them that these were implemented in social places. I did a lot of advocacy, and usually we tell them, we go with data, say, this is implemented in social state or social country, and it has worked. Of course, not every country, but a country that could be compared with Nigeria, of course. Yes? So the next on the format is also propose simple and evidence-based strategies. If you say these are the solutions, of course, you also have to talk about the strategies. These are ways we could follow to achieve this objective. And then also, to convince them, you have to talk about the impacts and the benefits. Provides information on the benefit of the expected outcomes and the results of the intervention, so that the policymaker will be fully aware of what he's about to invest in. This is for high-level advocacy. Remember, we're doing both demand and supply, right? So, same format for the demand side. When you go to the community, this is how you're going to as your information. Show them the need, why you want them to engage in the behavioral change you want them to do. We want you to change your ways of lives because of this. Show them the need, tell them the data in their own native language, using simple words that they can understand what you're saying. Tell them in workable solution. Of course, in the community, you're not going to tell them do this as per a strategy of supply. No, you can now tell them possible ways. If, for instance, give me an example. Any behavioral change. So you could just tell them, okay, maybe let's use cholera as an example. Okay, we want to, curtail the spread of cholera. Of course, under workable solution, you now tell them what do they need to do as a household, as a mother, or as a family member. How do you, contribute to curtailing this disease at your own level? So you see, in both sides, the format is the same, but then the content differs. I hope I'm passing the information right. So the next, okay, I think this is, yes, the end of messaging. We're going to number 5 of that, of preparation stage, mobilizing available resources. Of course, we have the plan ready, everything is ready, and then what resources do we have to embark on this advocacy journey? So we look inward. That resources that we have within, let's mobilize and see what we have before we now move to the next stage. So I will not waste time on this. We're going to the next, that is implementation. Next slide. Implementation, pre-implementation 2, and that is all about partnerships and collaborations that Dr. Magashi has just explained. We need to collaborate and partner with a lot of other organizations, for all forms of support in what? Either cash or in kind to implement our advocacy. I will not waste time on this because he has explained very well and it's all cut across this. So we are now moving to second stage of implementation. That is implementation 1. Next slide. No? Where are you? I can't see. Yes, okay. So, in the implementation, this is the main action. The other one was preparation. Now you are on the field to conduct your advocacy. So let's see, what is the first step? Reaching out to general public, that is in the aspect of creating. We already have our general public as grouped here, already mentioned. So now the question is, in creating demand, do we reach out to them directly or we use some forms of communication? Mind you, which I know you know, I just want to remind us that, be it we have very good messages that is developed or was developed using simple language with all the data and relevant information to support it. Sometimes when we advocate to them, they will not be convinced, simply because the information is not coming from one of their own. There is this issue of trust, which we all know. That is why when engaging the community, this is purely community engagement. When we want to pass information to the members of the community, we have to use these channels of communication, and it has been implemented in a lot of places, and it has worked. I implemented it several times, and it has worked, which I know a lot of us here have done it. It was even mentioned in the presentations yesterday. It has worked. So how do we reach out to the community? We have our channels or agents of communication. Traditional communities, you reach out to them through their traditional rulers. The same thing with religious communities, through their religious leaders. Women communities, we have women leaders in markets and all of those places. In the schools, there are teachers and principals and head teachers, all of them. We could reach out to school communities through these targets, and then the informal groups. You remember, those informal groups is a collection of those out of school, the dropout, everybody that cannot fall under each of these groups is informal. So I have media and civil society here. So the media here, I'm not just talking about the local TV, radio, or social media. I'm looking at those celebrities in those movie industries and other things, jingles and some presentations from those movie actors and actresses, will move this audience to, because they trust them, they like them, and they will listen to whatever they say. So this is one. Next, how do we reach out to policy and decision makers? We reach out to them, yes, through meetings, dialogues. Okay, before I forget, so those agents of communication through which we are going to reach out to communities, we are also going to advocate to them first. And it's through the same strategy. Through meetings, we go for advocacy visits or courtesy visit to the emirs and traditional leaders and community or religious leaders to create their awareness with the same format, emphasize on the need, what to do, how to do, and explain or show them the benefits. So the community policy and decision makers the same. Through meetings, official gatherings, maybe they have their meetings, forum, or other engagements, we could chip into that. And then all other possible ways you could think you can reach out to them is welcome, because it's an advocacy. But then, do we need to use channel of communication here? Yes, no, yes, and no. We can advocate to them directly as advocates, direct engagement by us and advocates. Sometimes we need to use other influencers. Just to remind us that in some instances, an obvious office holder might not be the key influencer. Sometimes when we go for situation analysis during our advocacies, we emphasize on knowing the political economy of that state or of that community. We ask questions because during situation analysis, you want to understand the magnitude of the problem. So after analyzing the problem, you also want them to propose some solution, because you're doing back to sender, you're giving it back to them, so that ideas and information on possible best ways to address the problem should first come from those members of the community. This is also community engagement. This is the time when you now get all this information. Okay, if we want to see the governor, or if we want the commissioner, or if we want the local government chairman to listen to us, who do we go for first? You'll be surprised. They will tell you there's one friend of his somewhere, when you meet that person, if that person says anything, the governor doesn't argue with him. So, sometimes we need this information. So when we go for normal advocacy, we do our, we advocate to the people we have as our target audience, but then we should not forget these other influencers by the side. So sometimes we advocate to them so that they lend their voices in also promoting our acts to those policy and decision makers. And again, sometimes we have to use advocacy champions in the state. Of course, issue of funding, if we're going to advocate, I remember my group yesterday, we were to develop a plan to create family health department in Ikiti, I can't remember the other two states. So if all the team members are here, we can't be going to Ikiti every now and then. So we should have champions in the state. Of course, we'll have a quarterly visit, monthly visit, depending on how we design our plan. But there should be an advocacy champion in that state to follow it up, and to be feeding us with information. Yes? So this is stage 2. Now, reaching out to all other target audiences. We're reaching out to them through the same strategy, meetings, dialogues, seminars, or special lectures, official events, and all other channels or strategies you may think of. But I have a question here. In this, do we also need to go through agents of communication, or it has to be a direct engagement? Please, anybody, so that I know we are following. So, okay, yes, sometimes we can reach out to them directly, and sometimes we could use, of course, medical association, there are leaders, chairman, NMA, nurses associations, pharmacies associations. Depending on how we want to approach that, we could go through their agents of communication, or we could reach out to them directly. Okay, so next. Order of advocacy. How do we advocate? There is bottom up and bottom down. So remember our two strategies, advocating for demand and advocating for supply. So for advocating for demand, the best approach is what? Top down. We have to go to them through these traditional leaders, religious leaders. If we go to them directly, they will shun us. I don't know if I have time. I want to share an experience quickly. Okay. So there was a time we wanted to do mass drug administration for psoriasis in the northeast, Borno, Yobe, and Adamawa. So I was working with the former First Lady Aisha Buhari. So thinking, because we have the voices, we are from Aisha Buhari Foundation, we just went, met with the Ministry of Education. We've had our planning meetings, and then we went straight to the schools and distributed our consent. So we shared the consent form to those students to take back home, yes, for their parents' consent. So after 2 days when we came back, everybody was no. Wow, it was so, so we came back to Abuja. We were like, okay, so we now said, okay, let's re-strategize, because before we thought we have the voices, so we now went back and we went to engage the community. So we went to those traditional leaders in these 3 states. So we engaged them first. We sent an initial letter to tell them that, yes, we are this office from the office of so, and we are coming for this. And then we attached another letter, asking him to please, mobilize all other district heads that are under him, because we are coming to deliver a lecture, something like that. So when we went, I am from Borno, so I did the presentation in Kanuri. The whole presentation of cysticercosis from infection, the bladder CA, everything using the local language. The same thing we did in Adamawa and in Yobe, with all the, the emir himself and the district heads and the religious leaders. Everybody was there. Wow. After that engagement, we came back. Before a week, we got a letter that we should come. And we went back and we did really amazing. So that is community engagement for you. So top down is always best for creating demand. Then for the other one, to increase or to improve service delivery, I don't always want to use increased service delivery, because this is advocacy. You are not, we're not going to give all, do this, increase this. No, we are lobbying, so we shouldn't say increase. We can use improve, which increase can come under it, and at all, if they are not going to increase, this that we have, let it be improved. So for advocacy to improve maternal and child health care services, bottom up is always better. When we go for advocacy with Her Excellency, the Special Advisor, what we do is we advocate to those other top government officials first before seeing the governor, because they also have their own concerns that they want a listening ear from the governor, and they didn't have that opportunity. So they will also tell us that, they will tell her, yes, ma, we also have this and this. We tried to reach out to him, but he didn't granted us the audience and things like that. So we advocate to those other people first, gather all the information we needed, because we are not from the state. We may not know what they really need and some of their challenges. So we hear from them first. We be fully kitted, and then we see the governor and we present everything to him. There is a state which I don't want to mention again. The SA went for an advocacy. In that state, the governor doesn't recognize the commissioner at all. You know this political issue? She was brought there, I think, I can't explain it. So to him, she's just not there. But so when we went for advocacy, you know, she explained everything to the special advisor. And when the SA saw the governor, I'm telling you, she called us. She was saying that all her memos have been approved, that now she's even happy that the governor will call her. They will sit one-on-one to discuss on some of the challenges, maternal and child health care challenges in the state. So you see the power of advocacy. So it's always good to go from bottom up in high-level advocacy. So, next slide. Frequency of advocacy. That depends on the magnitude of the problem. It also depends on our pockets, the funding capacity of the organization or of the team or of whoever is going for the advocate. That is why I now brought the issue of having state champions or advocacy champions. Yes, so it can be quarterly, it can be monthly, etc., depending on the type and the need for the advocacy. This is straightforward. So I'm going to the next. That is implementation stage of implementing a plan. Implementation 2. Sorry. Next slide. Monitoring and evaluation. So we are taking them one by one. For every intervention, be it advocacy, direct service delivery, we need to monitor and evaluate. Why do we monitor? To assess if implementation is according to plan. What is the point when we waste our time to develop a very good advocacy plan and then we're doing the advocacy just like that without following our plan? We may not achieve our objective. It's a wrong thing to do. We also want to monitor to assess any progress towards achieving success by measuring the set of indicators outlined in the action plan. Of course, in our development of action plans, we're going to identify some indicators, measurable indicators that will guide us, that will give us information. So this point is very, very important because sometimes you may be adhering to the plan, you may be implementing according to plan, but then it's not heading towards progress. Why? You need to identify why and re-strategize. Maybe how you have planned in the plan might not work. You need to change your ways. But how do you know that? It has to be through monitoring. So it's very, very important. You monitor and then you take informed decision towards achieving the success of your advocacy intervention. Next, evaluation. Although we know, let me just remind us that monitoring is throughout from the start of your advocacy intervention to the end. We monitor from beginning to the end. But then evaluation is a bit different. We want to assess if the advocacy effort has worked or not. For monitoring, to see if we are implementing according to plan, if we are heading toward progress. But for evaluation, the whole of the intervention, has it worked? Is it something to replicate? Is it a waste of resources, or is something to be happy about? So, evaluation can be in 3 stages. We could do an initial evaluation, and then to assess the situation analysis I've been talking about from the start. That can be an evaluation, and then we can do midline evaluation to see halfway what we have achieved, and then you can do an end line. For some, they just do the initial and then the end line, but the midline intervention is, evaluation is also very important. So we're talking about evidence-based intervention, evidence-based interventions that we replicate from other people. How do they know that it's evidence-based? Because they have evaluated it and have seen that it has worked. So we're going to the next. Documenting challenges and lessons learned is very, very important for every intervention. After your intervention, you need to document what challenges have you encountered, what lessons have you learned, because this will now inform your next intervention. Learning from your mistakes, your challenges will perfect your next intervention. This is also straightforward. So, and then I'm now moving into the next topic, which is talking about ways of overcoming challenges in advocacy. So I have a slide of the common challenges in advocacy, but this is not just these ones. There are many other challenges you may think of or you may have encountered. But here we have inadequate funding, resistance from opposing interest, difficulty engaging decision makers, maintaining momentum and sustainability, conflict within advocacy coalition. Yes, if there is conflict or misunderstanding between advocacy coalition or team members, of course, work will not progress. Poor planning. We all know what this is. Unrealistic goals and milestones. Of course, you know, advocacy is different from direct service delivery. For service delivery, this is something you're going to do on your own or by yourself, or you authorize someone to do it. You could see the result there and then. But for advocacy, you're going to ask, you're going to lobby someone to do it. You put a lot of efforts before you will record a slight change. So it's a difficult thing to do, so we shouldn't be too over this thing in identifying our goals, milestones, and our indicators. Poor monitoring. I just explained the importance of monitoring, and then we know the opposite of that, what will cause us. Poor messaging is also a problem. And I can remember the facilitator yesterday was commenting on my group. She was like, we've given too many information to the governor. At the end, he just emphasized of one. So you see, we have to be concise, you know, straightforward to what we want to do. We should not bore them with too many information. The same thing with the demand creation. Don't give, you know, the information has to be simple and straightforward so that they know what the problem is and they know what to do in terms of behavioral change. So messaging is key. And then all of those other challenges that you may have encountered. So how do we overcome advocacy challenges? Building strong relationships is key. Just like Dr. Magashi has explained, the power of partnerships and collaborations. All these funding issues. You know, the second stage in pre-implementation is building support. How do you build support? It's through partnerships and collaborations. You bring this to the table and the other partner will bring the, in partnerships you gain all the support that you don't expect. So develop a strong coalition with diverse stakeholders. Of course, the wider your, the complexity of your, or the composition of your stakeholders, the further your voices can go. Engage in constructive dialogue with those opposing interests. So, the second thing to do is effective communication. So develop appropriate messages using simple words and local languages if deemed fit. Remember, I said when I went for this community engagement in Maiduguri, we used our local languages to, you know, sensitize them. Utilize not only the social media, but also the traditional media outlets, yes. Identify experts among team members who could convey the message. Oh, sorry, there's a spelling mistake here. Conveniently. Yes, there are some talents or talented persons amongst us who know how to convey this information. They have this convincing power. So we should identify them and use them in passing advocacy messages. And then we should always use data and other relevant information to support our arguments. So next slide. Installation is another important step in addressing challenges. Installation, like in every other project, is to look within. We are going to embark on this journey of advocacy. What is our capacity? Do we have the staff capacity? Do we have the competence, people among us to deliver this advocacy? Do we have all the resources? Do we have all the materials? So we should look inwards and then assess ourselves and then install, secure adequate funding and other resources during preparation stage, which we have just explained the preparation stage and what should be done. Recruit and retain talented staff and volunteers, and then train staff on strategic advocacy. So this is installation. Before you embark on the project, look at your gaps, identify them, and try as much as possible to fill those gaps. If you cannot do it within partnerships, collaborations, it's always key. Next is community engagement and use of appropriate channels of communications. I also just explained that. The next one is we should stay focused on our missions and goals, and this will what? Enforce continuous monitoring, evaluation, and improve our strategies, for success. If we are focused, we will be mindful of our implementation. We make sure that it's implemented according to plan. And then we should learn to resolve conflicts or misunderstandings amongst team members immediately, because any form of misunderstanding among team members will affect the implementation of our advocacy. And then many other ways you could think of to address those challenges. So the next paragraph, the last one is the last topic, leadership and capacity building. So in advocacy, we have leadership in all our interventions. Everywhere we have leadership, not only in advocacy, but what are those qualities of a good leadership to be able, or that will provide an enable environment for us to achieve our objectives? A leader or a good leader in advocacy should be a visionary. The leader should inspire and motivate others to work towards a shared goal. As a leader, it's not only about ruling, about governing, about overseeing. It's about creating a change in people. How can you create a change in this person you are leading? This is a leadership. So a leader should be a strategic thinker, develops and implements effective advocacy plan. A leader should be a collaborator. We just talked about the importance of partnerships and collaboration. A leader should be a good collaborator to build those coalitions and partnerships. The leader should be an emotionally intelligent person who will now emphasize with diverse perspective. And then a leader should be a coach and a mentor. It's not about being a leader. Yes, I'm the leader, you do the rest. No, I'm the team lead. I cannot involve myself in the planning and other things. You report to me. This is wrong. Servant leadership is always the best. Be a coach and a mentor, and then provide mentorship and guidance to support emerging leaders to observe, engage, and experience leadership tasks, because tomorrow you might not be there. Those people will take off. So you need to groom them. So we have to how do we get a leader with these qualities? So let's go to the next slide. How do we get a leader with these qualities in our advocacy team or advocacy hub or advocacy organization? First is identify leadership potential. So we have to recognize advocates with strong passion, commitment, and leadership skills. All these three go together. If he has good leadership skills, but he doesn't have passion for that, what do you think? He might not exercise the services as is expected. So the person has to have the passion, has to be committed, and then have a leadership skills. We identify those persons. And then among the leaders you have, it's good to continuously conduct a needs assessment to determine leadership gaps among the advocacy leaders. And then you always identify or organize a training to close that gap. We could train advocates on strategic advocacy. Like now, we are all advocates, and we are in this workshop, to increase our knowledge and skills in advocacy. So effective communication is another key soft skills that need to be trained. Policy analysis, leaders have to be trained on how to analyze policies. Leadership skills, conflict resolutions, like I say, is very important, because any misunderstanding because we are looking at a lot of partnerships and collaboration. So when there is conflict or misunderstanding, which can easily happen within team members or within coalition, so a leader has to have distinct qualities to resolve things peacefully. Fundraising capacity, yes, and then the governance, of course, and then etc., etc. All those other relevant skills and knowledge a leader should have. And that brings us to capacity building. Because if we identify or we conduct need assessment and there are gaps, we need to train these leaders or to close those gaps. How do we train them? It's through capacity building. So what does capacity building do? I know we know. I just want to remind us, it helps to ingrain the necessary skills, knowledge, behavior, and attitudes required to deliver high-quality services. When staff are properly trained, they are able to work more effectively and efficiently to provide the desired result. This is so. So, why capacity building? Why do we train? So there are, should I call them objectives of why we train? We train for innovative purposes. When we are anticipating problems, we train staff to fully kit them to address the anticipated challenge when it comes. The second objective is problem solving. It's good to train staff to address problems at hand. For example, training supervisors or leaders on communication and other relationship skills. This is, for example, in the case of advocacy. Or training health workers on medical screening and, training health workers on medical screening and vaccine administration, etc., etc. So this workshop that we are doing also falls under problem solving because there's already a problem, high maternal and child death, and we want to address this. And we are having this to increase our knowledge and skills in advocacy. So the last objective of training is it's just regular trainings where there is a regular or routine training in organizations or companies. It includes training and retraining to keep staff updated, and then orientations for new staff. So these are capacity buildings in all interventions and also in advocacy. So methods of the training, if we want to train, there is on-the-job training and there is off-the-job training. On-the-job training, as the name implies, yes, you will be working and then training at the same time. It involves job rotation, job instruction, or coaching, and then committee assignments. These are ways we learn in the office, on the job. And then off the job, as the name implies, getting trained elsewhere, not in the office, or it can even be in the office, but then not engaged in the work. And we have the vestibular training or the lecture method where it's like a classroom setting where participants are trained. It can be role-playing, the one we did yesterday. It can be during conferences or a program instruction, similar to job instruction under, please, the next slide. Yes, okay. So on-the-job training and off-the-job training, I just explained it. Yes, so the next please. Types of training. We have technical training, depending on the type of job. Yes, quality training, skill trainings and soft skills training, professional training, team training, managerial training, safety training, and others. Thank you. Next slide. Yes. Thank you for listening. Really?
I think she deserves a louder round of applause. That was holistic. Okay, we'll take maybe two questions of feedbacks. That was very elaborate. I'm sure. Questions, feedbacks, disagreements, agreements. Doctor, I'll bring the mic to you. Somebody must say something. Doctor, I'm coming to you. At least one person must say something. Okay, Dr. Ige.
Thank you very much for that presentation. Please, I want to know maybe how important is advocacy kits when we are trying to visit the community stakeholders, and what are the contents of advocacy kits? Thank you.
Okay, advocacy kits is really very important. So let me start from the contents. In your advocacy kit, I'm assuming I have a kit now. Maybe I have a very nice bag. You should have the advocacy brief, that information that you need to share, because you cannot say, okay, I'm going for an advocacy. You go there without documenting anything. Even if you are a genius, you may forget a very valid point. So it's always good to have that advocacy brief. In the format I explained, you should emphasize the need, what to do, how to do, and then the benefits of the intervention. That is the advocacy brief. An advocacy kit should also have a fact sheet for that state, emphasizing on the information, maybe the mortality rates in that state. An advocacy kit can also contain a short clip or a video. Let me share an experience. I can remember we were advocating for increased ready-to-use therapeutic food, which is a remedy in the treatment of severe acute malnutrition. So we went to Jigawa to advocate to the then governor, Mr. Badaru. So before we went, we sent our media team to go and do the commentary of those patients in the hospital with the name of their hospitals broadly written, So we went to him with that clip. When we explained, we craved his indulgence to watch the 5-minute video, and when he was watching, he was like, really? Is this in my state? And the name of the hospital is there, the words are there, so it's so convincing. So an advocacy kit should have a short clip or a video, and then the workbook, which I also explained, is very important in monitoring. And then, apart from that, all other things that will be relevant for you to convince that person, you can put it in your advocacy kit, depending on what advocacy you're going to embark on. If you're going to the community, of course, you're creating awareness. You may not need all of these fact sheets and other things, but you have to kit yourself with the relevant information that you need to pass. You may want to share some materials, advocacy materials, the T-shirts, the other things, even for them to come to that maybe town hall meeting that you're organizing that you want to discuss with them. So I think I've answered your question.
All right, that was a very elaborate session. We'll be going straight into the next one, which is media and communication. So we'll take this one before we now go for tea. Media and communications for advocacy. We'll look at using media for advocacy. We'll also look at crafting key messages, press releases, and the likes. And the person who will be taking this is a prime development leader who has accelerated impact and leadership, 20 years of managing large and complex international development programs and consulting opportunities. She's a sector leader with sectoral experience in health, education, governance, humanitarian emergencies, and the media. Of course, that's where she started her career from. She is a leadership team that builds, she's a leader, that builds leaders globally, and a member of Rotary International, an associate member of WIMBIZ, and a board member on the Rotarians Against Malaria Action Group Global, RAM Global. She is passionate about women and children and drives support through the Herd Africa initiative. Please let's make welcome Akaoma Onyemelukwe for this session. Please let's put our hands together and appreciate her.
Good afternoon or good morning. I'm not sure what time it is. It's still morning, okay. Okay, so today I will just be speaking to you about using media for advocacy and crafting key messages. Doc, who spoke before me, actually shed a lot of light on what advocacy really is. But you know that the media has a lot of power. And in today's world, the media has to be your friend. So in your advocacy, if you do all the community engagement with leaders, engagement with policymakers, and you don't engage the public, and you don't use media effectively, it will be like putting up a lamp and covering it with a bushel. So, what? Okay. Okay. So covering it with a bushel. I don't know whether you can see my slide. Is it legible? Okay. So in terms of objective, our objective basically is to equip us with skills and knowledge required for leveraging media for advocacy, and then, enabling us to raise awareness, influence public opinion, and drive policy change. So while you're doing advocacy at the different platforms and levels, building partnership, media brings that extra power. And media today can transcend beyond Nigeria, beyond your state, beyond Nigeria, into other countries to say, this is what this program is doing, and this is the effect you're having. Just to reiterate some of the definitions that we've seen today. Can we move on? Keep moving. Okay, yes. So, advocacy is the act of actively supporting, promoting, and arguing a cause or policy, or group of people. So in advocacy, sometimes you're acting for, and sometimes you're acting with. You understand? So it depends on what part of the advocacy you're doing. So it's actually the strategic effort to influence decision makers, mobilize communities, and bring about this change, social change or policy change. So in maternal health, we know that there are a lot of social change that needs to happen with many of the social norms, addressing delays, and also policy change that are important, like we've been mentioning, things around financing, creating access, increasing utilization, and also bringing incentive. For example, when the director was here earlier in the day, yesterday or 2 days ago, he spoke to us about cesarean section being free. Okay, that's a policy change. And we then have to ensure that it goes down to the communities and the PSC level, and that health workers would adhere to it. Okay, so it seeks to amplify voices, the voices of women, raise awareness, and create meaningful impact through various forms of engagement. So it's either we're educating, we're lobbying, we are using campaigns, or we're having public speaking. When we understand advocacy and also the role of the media, we understand that the media is so powerful in advocacy. And they help us with raising awareness. We've talked about that. They reach a wider audience, ensuring that the public is informed and engaged. They shape public discourse. So how do they shape public discourse? By framing the narrative. What do they want the public to hear? Once you tell them what it is, they write it in a way that the public can digest it, and you start hearing it everywhere. And they focus on the specific aspects of the issue. So if it is maternal death, mortality, that we want to end, we can actually promote that, and they frame that. Once they frame that, what you will find is that that's the topic people keep talking about. They amplify the message, okay? Enabling advocates to reach a wide audience quickly and spread the message through news stories, opinions, social media campaigns, and others. There are various types of media. We have the traditional media that many of us know, which the younger people don't use anymore. So the traditional media is the newspaper. But the newspaper is still very reliable. So you have Punch, you have Daily Trust, you have Guardian, and things like that. You also have radio. Radio is so powerful and wide, ranged. A lot of people listen to radio. Then you have the television. These are platforms that are broad reach and are seen to be credible. So beyond reaching audience, they're also known to be credible. People believe what they say. You have the digital media, online news, the blogs, and all that. Then you have the other platforms on social media. You have YouTube, Twitter. So depending on what you're doing, okay, there are some of our policymakers that I know that once it's 10 p.m. every day, they drop a message, they drop a post almost every day on like Twitter and the likes. Okay, Instagram, LinkedIn. LinkedIn is so powerful as well. Then you have the community media. That's the local radio stations, the newsletters in the community, the town criers, the different group meetings that are there are also used by the community to target specific issues and specific strata of people. So for you to understand the media landscape as well, you have to understand that media shapes the public opinion. Many of us see things that trend, and we ask, why are they trending? They trend because the media, the power of the media is very, very, very clear, affecting that and moving that issue. So the media sets the agenda. And in setting that agenda, you find out that everyone begins to talk about it. Everyone thinks about it. There was an ad that I saw recently where women entered a plane, and a lot of pregnant women entered a plane. And there was an illustration that looked as if the plane crashed. When you see that was actually a media message to show what happens with maternal health. And it was very wide. A lot of comments were coming on it because of that picture. I saw it on Instagram. So you find a lot of people talking about it. And when people now see people who are pregnant, they're asking you, have you gone to the hospital? Have you registered for antenatal care? Have you done this? Have you done that? Have you taken your vaccination? Those little things are important. So everybody takes responsibility. They also frame the issue. So they present the issue through headlines. You find the headlines on our newspapers, on our news blogs. And so some of those headlines actually shape how people think. So framing a health crisis, maternal mortality is a health crisis. So we frame it from a human rights perspective. We frame it from a healthcare management failure or gap. And this evokes different levels of responses. Some will be against, some will be for. But once it is something that has to do with life, you will find out that more people would want to step in and ensure that more people live, that women live. And that's what we want to do. Then the media exposure can influence how the public evaluates leaders and policies and events. Priming. So sometimes the media could be used to either make someone look bad or good. So if you use your media properly, it will bring out the issue and help you present that issue that this is what we should be talking about now. It's as important as eating food. It's as important as every other issue, if not the number one top issue. Next. So in our media issues, in dealing with the media, you find out that journalists, reporters, editors, producers, influencers, bloggers are critical. Editors are the people who make many of the decisions of what will come out or what will not. So in using media in your advocacy, you need to know who the editors are. The editor of Punch, the editor of Daily Trust, the editor of NTA Networks, or AIT, and all that. You need to know who they are, and then reach out to them. So usually programs will have a media team who they engage. Then producers of the different programs, educational programs, health programs, then journalists that report health, or journalists that cover stories. Okay? They could actually take time to go into the communities, go into the facilities, and do some investigative journalism and write stories that would really reach the people and also reach the policy makers. Then influencers and bloggers. One of them could be some of our celebrities. We already know that if you're on LinkedIn, for instance, and Instagram, you will see some of our celebrities already championing maternal health issues. For instance, the USAID Advancing Health Nutrition, Helen Keller project. So they're already using that, and you find that those celebrities are celebrities that are already known to be women or men who already stand for maternal health issues and are very, very, very passionate. These content creators and influencers, they have very wide following. Some have 10 million people following them. Some have 20 million people. So with one post, with one 5 minutes, 2 minutes, 1 minute video, 20 million people will be reached. 20 million people. So if he or her shares such of your messages, 3 of it every day for 1 month, it's saturation. Okay? It's saturation. So you need to think about this as you do your engagement with the media for advocacy. So it also demands that you understand how media products are consumed. We've talked about trending. So sometimes on social media, you find out that things that trend, sometimes they are very trivial. And the attention span is very short. So you have to look for is that, how do you couch that message to reach people? So there's a shift to digital. From the analog where we read newspapers, sitting down, to digital where everybody has a device. Is there anybody here that doesn't have a device? So we've moved to digital. Audience are consuming news on online platforms and social media. So you need to understand the trend. So you need to choose your channels right. So we've said that there's a rise in the mobile news, videos, use of multimedia videos, infographics, and those kind of things, than texts. So it means that some of the advocacy campaigns that we'll be planning going forward, we have to incorporate the digital platforms into it. Sometimes even just forwarding messages on WhatsApp can create a lot of traction, okay, than just the newspapers. One of the other things you need to also understand when you are looking at your media landscape is media ownership and bias. There are media institutions that are biased to women and girls. They are biased to social issues. Some are very commercial. Okay? So that will determine where you should go to. Some are very commercial. Some are anti-government. So it depends on the philosophy that guides each of them. So identifying independent, credible sources for your strategic advocacy is what we recommend. There are laws that we also need to take cognizance of. Free speech is important. There are censorship issues. There are media ethics. So the people in the media will actually always guide you on this. But it's important that you know it as you prepare your engagement with the media. Then they are adapting to new media. We've talked about technology. There's AI-driven news reporting now. So you have to check. Then live streaming platforms. So some people have Facebook Live every Tuesday talking about this at 12 o'clock because at that time, many people will be on their device. Some people will have it on LinkedIn by 5 p.m. every Tuesday, or we'll have it on Instagram, depending on what you plan to do. But you have to be consistent. So these are some of the channels, media channels. You have your print media, you have your broadcast media, you have your online media. The print media is still there. Newspapers, magazines, journals, printed. The broadcast media is our TV, radio, and the online media is mainly of all our digital social media related. So these are advantages of using any of them for your advocacy. So when you use the print media, it is seen to be very credible. They will always publish news and stories that are verified. And the policymakers read many of those newspapers. So if you want to target policymakers that are within the Northern Hemisphere, you have to use Daily Trust. If it is within the South, you use the relevant newspapers in those locations. And there are also newspapers that are nationwide. So you have to know which paper to use. And the spaces are detailed, well-researched articles, and they explain complex advocacy issues. So they're able to talk about the issues with the data, with some of the narrative, with some of the stories. So somebody reading will have all his questions answered. And you also have opinions. But the limitation is that younger people no longer find reading newspapers very attractive. They still do, but not so much. The broadcasts is our TV, radio, and I know that the radio is very widespread. You have BBC Hausa Service, you have VOA Hausa Service, you have Radio Nigeria. All these radio stations plus the FMs are very widespread. They have very wide listenership. So it's also a channel that is effective. So it's accessible. It reaches the audience in the remote and rural areas. The limitation is that the time slot is limited for in-depth discussion. Okay. And then, once it is aired, it may not come up again. So usually, some of them would have repeat broadcasts, and that repeat broadcast helps the audience who missed it to listen in again. The online is very high competition for attention, so you use very short videos, 1 minute, 2 minutes at most, to do that, to engage people to stand out. And it allows you to really reach directly your followers and have rapid mobilization for support. And it could be interactive and offers real-time updates. So you can choose anyone that works for you and arrange to use it, but usually we recommend that you use a mix to have the value that you require. So these are your media outlets. If you want to reach out to journalists for your advocacy, these are the steps you will take. Next, please. Next, yes. You define the target audience, you research the media outlets, and then you build your media database and you develop relationships. So when you are defining the target, that's the target, your audience. Your goal is to influence policymakers, so you aim for the respected newspapers and journals. Because those newspapers and journals will make it into their cars, their homes, their offices. When they are relaxing, that's what they would read, usually. So, but if you're trying to reach younger people, it will be online platforms and social media influencing. Then if you're researching, for you to research the outlets, we've talked about the different media channels. There are many of them. So you have a list that you can pick which one, based on the biases that they have or what they do, and then which one supports the cause of maternal health that we stand for. You identify journalists that write in those areas. You identify journalists and reporters and editors and opinion writers, that actually focus on health, on maternal health, and then utilize the media databases to get their correct information, their correct contact information. You utilize the website of the media houses to also help you to get adequate information that you will be needing. So beyond that, as a program, as an organization or individual, you will then develop your comprehensive media contact lists. That list is a list you have to use all the time, and you continue to add to it. So it's not when you have something you quickly look for, but if you have them, you have a relationship that helps to ensure that consistently your advocacy issue is in the media and on the front burner. So you develop your pitch showing why the issue is urgent. Maternal health is urgent. Addressing maternal health issues is urgent and important, and why they should give it attention. Okay? You build and maintain relationship with your media team and support your advocacy efforts. So when you're crafting your message, next please, quickly. When you're crafting, no, forward. Back. Keep ahead. You've missed it. One more. Yes. So this is the steps to craft the message, advocacy message for the media. So you define the goal and objective of what you want to do, what you want to bring out in the media, and your goal speaks to the overall aim of the advocacy. The objectives are the specific actions that contribute to the goal. Your objectives must be SMART. Then you identify the target audience. Your primary target could be policymakers, especially when you're talking about policy change, social change. It will be policymakers. The secondary audience will be maybe leaders, religious leaders who persuade and mobilize the community. Then you develop clear, concise key messages. So there are core messages that you could develop. Your core message will be additional funding for maternal health, for instance. Okay, ensuring that your state governor actually allocates more money to health. And then you have supporting messages as well. And there must be a call to action. What will you want them to do? It must be part of what you will add. Then you create a messaging framework. The core message, the evidence. That evidence is the statistics, the emotional appeal, telling them how this will better the people. And then the response, you prepare a response to address any misconceptions that may happen. So when you want to write your press release, next. So when you want to write your press release, this is the outline where I have to wrap up very quickly now. And your press release needs to be easy to read, easy to share, and easy to repurpose. So the media team should be able to use your press release and coin different perspectives of work and stories from it. So that's a guidance on what the structure could be. A headline, a lead paragraph, quotes, and then a description of the organization and the contacts, information on who signed off on the message. Then you craft your compelling headline, You can actually work with a media organization to do this. That's an example there for you. New initiative launched to combat maternal mortality in rural Nigeria. That could be one. I think on the first day we had a lot that were said that we could use as very compelling headlines, actually. Then you have your lead paragraph, and I just did an example. I said today, can you move, please? The last example, I said today, Rotary Together for Healthy Families announced a landmark initiative aimed at reducing maternal deaths in Nigeria by providing access to emergency obstetric care in underserved regions. This could be a headline or and then start off the lead paragraph. And with that, people will want to know who is Rotary Together for Healthy Families and then what exactly did they do. So the other things you need to know is that key for media, journalists, next slide, journalists are looking for newsworthy pieces. So your piece must be newsworthy. If it's not newsworthy, they will not use it. So it should focus on what makes your announcement timely, relevant, and impactful, and the language must be clear. No jargons, no abbreviations like we use in health. It has to be clear and easy to read, easy to quote. And then for the public, you make the content, replicable in such a way that they can relate with it and engage with it and be able to discuss it. So simple languages are important. Human interest angles or emotional appeal is important. So you're painting a picture how this will end sufferings, how this will, avert deaths. If you remember, if you were here on the first day, one of the things that was said was that we are working on making sure that every pregnancy is wanted, right? And every child that is delivered survives. Those actually paint that picture for you. So if you put that in your press release and someone reads it or it's transmitted on broadcast media, you will find that you will connect to people very quickly. So policymakers require statistics. They require statistics and how that initiative aligns with the policy priorities. And then you also need to include key facts, statistics, and quotes, and dates. And then you also need to distribute your press release. Social media is very clear. We already know it. So you leverage on the different platforms and understand them. They're not the same. And you use influencers, and you're consistent. It has a lot of analytical tools that can show you how well you're doing, whether you're reaching the right target, and a lot of people can help you build on that. Then you can also have media interviews, and you prepare for your media interview. Okay, your media interview is critical. You prepare, you know the facts. I gave an example with dates and with statistics. Then you prepare your stories. Next. And you prepare to handle tough questions, really, because reporters, one of the critical things they will do is they will ask you those tough questions that can throw you off balance. So you prepare to answer them. You bring them forward, and so that you would know what to do. But you must be calm, focused, and in charge, really, because it is your interview. Your body language is required. Your body language must be right. You have to learn the different body languages. Your facial presentation as well. You can practice mock interviews that would help you scale media interviews like this. So in terms of action planning, these are the steps you can follow. Next, please. Next. Yeah. So action planning, you can follow these steps. I think, okay. You identify your goals. You develop your media strategy. You build your media network. You craft your messaging. You practice and refine your interview skills. You engage on social media. Then you evaluate your impacts. Thank you. Next. Thank you. Question and answer.
Thank you very much for that very insightful presentation. I think she deserves another round of applause. Sorry, our time is really pressed, so we won't be able to take questions on that, but I think it was quite expansive. And if you have more questions, I mean, you can still reach out to her and you'd get expert answers. So we're supposed to break for tea now, but please, it'll be a walking tea break, please.